I've got a question, I think, for the Permanent Secretary. I mean, do you agree with me that good data is the basis on which good decisions are made rather than bad decisions? That's how I've always run my businesses. I mean, do you agree that's a logical summary of how people make good decisions rather than bad decisions?
It is entirely how we would hope to do so, yes.
Okay, well I've asked a lot of questions through my parliamentary office. So, number of GP registrations by non-UK citizens, no data. Number of illegal accessing healthcare services, no data. Cost of treating those with no right to be here, no data. Nationality and immigration status of NHS users, no data. Patient category F breakdown between illegals and visitors, no data. Cost, monetary and time of translation and interpretation across the NHS, no data. On questions about standards of English in the health service, I've asked what steps you're taking to ensure overseas recruits can speak English effectively. I haven't had an answer. So I'm interested, my first question is, I'm interested to know, if you don't have this data, what do you think are the reasons these clinical negligence damages are increasing so much at the front end, not the legal end? So why are we getting these cases
with your permission,
increasing?
If I can hand over to Aidan as the doctor, thank you.
Yes, please.
Thank you.
Thank you.
So, thank you. I think the first thing to say is that clearly we work all the time to drive down cases of harm. There isn't evidence that those are increasing, to be clear, and in fact the level of claims has not been increasing for a while now. We are taking considerable efforts around patient safety and levels of harm, and believe we have had impact on that over the last period of time. That has been through a mechanism of the patient safety strategy, which was the first strategy for patient safety that the NHS has had and was published in 2019. It was published just before we had a pandemic. Nevertheless, we have made good progress with that work, including through the pandemic. And while it is difficult to estimate, we estimate that we are avoiding 1,000 deaths a year that would have occurred had we not done that work, a fundamental piece of work around how we learn from the system, how we investigate, how we involve families in those investigations far more, and patients, how we report and how we learn from that reporting. And we have a massive database, to your right point about data. We have a database with 3 million incidents going into it a year from which we're learning. To be clear, to reassure you, most of those are no harm data points. So something has gone awry, but there has been no harm as a result of it, and that's about 70% of the data we see, and then another significant chunk of it is low harm. So it's the minority of those reports that involve either moderate harm, serious harm or death. But we're learning all the time from that. We have made reductions. That is estimated to save UK PLC, not necessarily the health system alone, hundreds of millions a year. But there is far more to do, and we continue to do that, and we continue to prioritise programmes around that. One of the difficulties when it comes to clinical negligence is there is not, one would assume if you reduce that you would see a reduction in litigation, but there is a difference between where we see the majority of the harm, which tends to be in older populations, and who litigates. So actually there isn't a direct connection between the two, and the areas where we see the highest levels of harm are not necessarily the areas where we see most litigation, although we aim to learn from litigation and clearly wish to see it reduced through the reduction of harm. I hope that's helpful.